Hello and welcome to your Harrisburg Area Community College Blended Learning EMR program. James Weber here to give you a little bit of a rundown on your chapter for behavioral emergencies. This is actually a pretty broad chapter. Deals with a lot of different things that aren't just behavioral from a perspective of psychiatric disorders, but a lot of things involving emotions, high emotions, violence, things like that. So it's a very broad chapter. So, a little bit of an introduction, right? EMRs need to give psychological support as well as emergency medical care, and our job at EMS kind of goes well beyond just putting band-aids on people, right? We've got to give that psychological support, and we've got to understand some of the factors that contribute to patients' behavioral changes as well as our own behavioral changes, things like medical conditions, trauma, psychiatric illness, mind-altering substances, and situational stresses. Behavioral crisis. Behavioral emergencies are situations in which a person exhibits abnormal, unacceptable behavior that cannot be tolerated by the patient or by friends, family, or the community, right? Medical conditions that can cause behavioral crisis are pretty broad. We talked about this in the last chapter. Things like uncontrolled diabetes with some respiratory conditions, right? As well as a patient experiencing a stroke can cause these behavioral changes. Medical conditions, head injuries, high fevers, infections, excessively low body temperature, physical trauma. Head injuries can cause unusual behavioral changes as well as injuries that result in shock and inadequate blood supply to the brain. Psychiatric illnesses, depression, panic, psychotic behavior, mind-altering substances, alcohol, and a wide variety of chemical substances, situational stresses, death of a loved one, serious injury to a loved one, all things that can cause significant behavioral crisis. We have to have an idea as to what can be the cause so we can identify what to do about it. What is a situational crisis, right? Let's define the broad question of the chapter. It is an emotional upset or turmoil. It can be caused and is often caused by a sudden and disruptive event. Most situational crises have kind of some common threads, right? They're sudden, they're unexpected, they can't be handled by a person's unusual coping mechanisms. They last for only a short period of time. They can cause socially unacceptable, self-destructive, or dangerous behavior. And there are phases, keep in mind, of these situational crises when they unfold, right? Not everybody experiences each phase, but they will experience one or more generally, right? Which is the reason why it's so important to be aware of how these situational crises work. High anxiety. High anxiety is characterized by a couple of different key common points. Things like a flushed red face, rapid breathing, rapid speech, increased activity, louder screaming voice, and general agitation. Emotional shock is often the result of a sudden illness, injury, accident, loved one, or a sudden death of a loved one, right? Emotional shock happens. It's actually relatively common where we start to see actual physical manifestations of the emotion that somebody might be experiencing. Things like cool, clammy skin, a rapid or weak pulse. How about things like vomiting, nausea, general inactivity? How about weakness, right? These can all be signs and symptoms of someone with significant anxiety and definitely signs and symptoms of a patient experiencing some emotional trauma. Denial. Denial is a refusal to accept the fact that the event has occurred. It's one of the stages. Response should be something to the effect of allow them to express that denial. Don't argue with them. And try to understand the fact that the patient's going through some pretty significant emotional and psychological trauma. Anger. Totally a normal human response to emotional overload or frustration. May follow denial and may replace denial. Patients will vent angry feelings to you. Don't take it personally. You are there to be that grief mop. Take it, process it, and allow them to do that venting. Right? Frustration and a sense of helplessness can often build to anger. Be professional, remain calm, and listen. One of the biggest things that we can do in EMS for these types of patients is to simply listen. Remorse or grief. Acceptance of the situation may lead to remorse or grief. Patients may feel guilty or apologetic about their behavior. That's common as well. Listen, right? Crisis management. Role of the emergency medical responder. Follow the steps of a traditional patient assessment. After the primary assessment, you may need to obtain a patient's medical history or perform a physical exam. Just keep in mind, the most important assessment skill with these types of patients is your ability to effectively communicate with the patient. Couple keys for effective communication with these patients, right? Keep yourself at eye level. You notice the EMS provider at the top in this slide has brought himself down to the patient's eye level. That's huge, right? Standing over them makes you appear menacing and changes the actual free exchange of information and the patient's comfort with that exchange. Introduce yourself, ask the patient their name, ask what you can do to help. Be honest, be warm, be caring, be empathetic. Establish eye contact with the patient. Use a calm, steady voice. Try not to let negative feelings interfere with your attempt to provide assistance. And some simple acts of kindness can offer comfort and reassurance. It really makes a difference. Whenever somebody actually communicates with you in this environment, it's important to rephrase person's own words and thoughts and repeat them back to the patient. Be honest and give the patients hope, but don't give them false hope. And redirection. Sometimes it's really helpful to redirect a patient's attention from the immediate situation or crisis at hand and get them actually focused on what's actually happening. Right? Redirect them back to that immediate crisis that's directly in front of them. Use redirection to alleviate a patient's expressed concerns. Move the patient to a quieter or more private location. Sometimes you got to kick out family members and actually effectively communicate with that patient, and that's okay. Do what's appropriate in that circumstance. Empathy. Imagine yourself in another person's situation sharing his or her feelings or ideas. Empathy is one of the most helpful concepts you can use. Use a calm and caring approach. Communication skills. Identify yourself and let the patient know you're here to help. Inform the patient of what you're doing, right? Inform the patient of what you're doing. Ask the patient in a calm, reassuring voice. Allow the patient to tell you what happened, and do not be judgmental. Show that you are listening by using restatement and redirection. Acknowledge the patient's feelings. Assess the patient's mental status. Crowd control. Performing crowd control may help reduce a patient's anxiety when there's too many people around, right? During your scene, size up of the scene. Determine whether the crowd might become hostile. Sometimes it's a good idea to call for police to help you with the control if need be, right? Be mindful of the crowd around the patient. Sometimes getting them out of that environment can be a game changer to being able to effectively communicate with them. Domestic violence. It's common, unfortunately. It takes a lot of different forms. Elder abuse, child abuse, spouse and domestic or partner abuse. When responding to a domestic call, maintain safety of all the rescuers as well as the patient. Conduct an effective assessment and treatment and understand the requirements for reporting abuse in the state, right? Because every single state has different rules on how you're supposed to report things like domestic violence, but anytime you have a concern with domestic violence, potential domestic violence, as well as child abuse. Physical signs and symptoms, broken bones, cuts, head injuries, bruises, burns, scars, injuries in various stages of healing is a big one because that's multiple different injury periods of time, as well as internal injuries, depression, suicide attempts, feeling of alcohol or abuse of alcohol or drugs, feeling of anxiety, depression, or hopelessness, right? Abusers may be paranoid, overly sensitive, right? Obsessive, or even threatening towards EMS providers. Just be mindful of that risk. If you suspect abuse, your responsibility is to maintain safety for yourself and for the patient. Try to separate the patient. That's huge, right? Try to get him away from the abuser. Try to keep from judging the patient. Presence of law enforcement, super helpful. And just be mindful of the fact that you might have some very specific state requirements for reporting abuse in your state. Medical legal considerations, right? If a patient is emotionally disturbed and they agree to be treated, there's really few legal issues that arise, right? But if the patient who appears to be disturbed refuses treatment, you may have to provide care against their will. You must have a reasonable belief the patient would do harm to themselves or others. If you can qualify that the patient would do harm to themselves and others, you can really engage in that care regardless. It's important to defer to the EMS providers that are en route, however, if you're not sure. If you're required to restrain a patient, consider some factors before you actually do that. And these are some examples. Just be mindful of restraint in any environment because it carries some pretty significant legal implications. You may use reasonable force to defend yourself should you get attacked. Make sure you get law enforcement officials or from your medical director whenever possible. Document conditions pretty heavily whenever you have cases where you might be facing violence. So whenever possible, caregiver of the same gender should take responsibility for patients of that same gender. Attempted suicide. Patients who fail at their first attempt will often try to commit suicide again. Underlying psychiatric disease is generally treatable. We got to manage these patients, protect themselves, protect yourself, protect the patient, get a full history to determine whether the patients have things like weapons or drugs that they can continue to hurt themselves with. Support the patient's ABCs, dress open wounds, treat the patient for spinal injuries, don't judge, treat the patient for the injuries and the conditions you discover. And the biggest thing is going to be provide that emotional support wherever you can. PTSD, it's a mental health or behavioral condition triggered by experiencing or witnessing a terrifying event. Symptoms include intrusive memories of the traumatic event, avoidance of all places, activities, or people that remind them of that event, negative feelings, and emotional reactions. As an AMR, got to protect that patient from harm, right? Speak with the patient in a positive and supportive way and arrange for transport quickly. Critical incident stress debriefing. You may need counseling to deal with some of the things we see in the field. Signs and symptoms of stress, depression, inability to sleep, weight changes, increased alcohol or drug consumption, right? Signs and symptoms also include things like inability to get along with family members and coworkers, lack of interest in food and sex. CISD, critical incident stress debriefing, brings rescuers and trained people together to talk about feelings, reduce that stress, and it really does a pretty good job at making sure that we're working through some of the visual connections to some of the things we see in the field. Quick summary, not everybody is mentally disturbed. Very small percentage will be severe, but almost every patient you care for will have some degree of mental or emotional crisis. These situations where patients have behavioral emergencies, they will exhibit abnormal, unacceptable, socially unacceptable behaviors that can't be tolerated by family, friends, or the community. That is the definition of a behavioral emergency. Lots of different factors to behavioral crises, things like medical conditions, traumatic conditions, psychiatric conditions, drugs, situational stresses, and there's a couple different phases to that emotional response to each crisis when they occur. Role of an emergency medical responder, provide care, right? Use that assessment as best you can, communicate in an efficient and positive therapeutic way. If the patient appears to be disturbed, refuses to accept treatment, you may have to provide care against their will. So this is just a quick overview on the behavioral health chapter. This is just it wasn't a deep dive by any stretch. I give you a little bit of a framework on some of the stuff you're reading in the book. Like anything else, if you have any questions, please reach out to your program coordinator. And should you need anything at all, reach out to them. We appreciate your time, your patience, your energy, and as always, we look forward to seeing you at our next lesson. Have a great day.